Hello, everyone. My name is Amit Iyengar, and I'm a cardiac surgery resident at the University of Pennsylvania. I'd like to thank the Society planners for allowing us to present our work today. This is a joint project between our group and the STS, looking at the effects of socioeconomic status on outcomes in patients undergoing mitral valve surgery in the United States. It's certainly not a surprise that socioeconomic status affects surgical outcomes, but other groups are increasingly demonstrating this in the cardiac surgical space. Much of the existing literature has been surrounding issues of access to care and outcomes in patients undergoing coronary bypass and aortic valve replacement. And this has been especially important as complementary therapies such as transcatheter aortic valve replacement are being introduced and distributed. There is somewhat of a gap when it comes to mitral patients, which are often different, younger, with varying types of valve pathology. It's also important to consider as technology for more minimally invasive and catheter-based approaches to treating mitral disease are being introduced and growing. Finally, there's issues of how best to quantify and utilize socioeconomic status in determining relationships to outcomes. Some have utilized singular metrics and others have utilized more aggregate measures. We partnered with a research center at the STS to utilize a relatively novel neighborhood-based metric of socioeconomic status and understand how it impacts patients undergoing mitral surgery in the US. We reviewed the national STS database of cardiac surgeries in the US retrospectively over a 7-year period. We focused on patients undergoing isolated mitral valve surgery, and we chiefly looked at 30-day mortality and rates of mitral repairs or peak outcomes. We linked the data in our database to a metric called the Area Deprivation Index, which is a multifactorial neighborhood-based metric queried by linking data surrounding a patient's home address. The ADI is calculated based on census and community survey data, and it's based on 17 metrics of socioeconomic status, including employment, income, housing, and education data over a given region. The data is refined all the way to the census block group level, which is a division of area far more granular than one zip code or county. And in this way is a much more accurate assessment of conglomerate socioeconomic status for a patient. The ADI is publicly available and can be found online at the following website. It's summarized into national percentile rankings where higher ADI values correlate with more disadvantage. We started by performing an exploratory and descriptive analysis of the relationships between ADI and our demographics and the outcomes that we had available. We then progressively developed hierarchical models to understand the impact of ADI and mortality and repair rate. And we compared these models to existing predicted risk scoring models that exist. We incorporated the effects of surgeon volume, region, distance, and center in our analysis. And our overall goal was to understand existing relationships between socioeconomic status and outcomes, and to identify and infer some plausible mechanisms of action. We had a cohort of 137,000 patients for primary analysis. We then identified a cohort within this that had patients with primary degenerative disease who otherwise might be expected to have a repairable valve. Overall, we had a patient population with a median age of 56, 82% were Caucasian, and 50% had primary degenerative disease. Of these, 62% underwent a repair with an overall mortality of 2.8%. The distribution of ADI values is shown here with a median value of 42. We made quintiles and we compared basic parameters between our groups. If you look at a few selected demographics here, you see that higher ADI, that is more disadvantaged patients, were more likely female, more often Black, and more often uninsured. Higher rates of comorbidities like dialysis and cerebrovascular disease were also noted. And higher ADI had more endocarditis, more urgent admissions, more mitral stenosis, and less degenerative pathology. Repair rates were much lower, with a doubling of the mortality rate out of proportion of the increased risk score for each patient. Visually here, a progressive drop in survival with higher ADI, and a very notable drop in the repair rate with more disadvantage. We then started looking at our modeling scheme, and we saw strongly varying odds of death with worsening disparity, and approximately 1.5 times increase in the odds of death compared to the median at extremes of disadvantage, and 0.5 times the odds of death at the extreme end of wellness. An even stronger relationship was noted amongst low-risk patients. We progressively built our model with more hierarchical terms. We found that ADI remained robustly significantly associated with mortality, despite accounting for a variety of other factors. When you consider repair rate, a similar story bore out. Even when you select for a cohort of patients that ought to have more repairable valves, a very tight association between socioeconomic status and rate of repair is noted. Again, we began modeling via a similar approach, incorporating a variety of other factors. And we saw that despite this incorporation, with progressive model building, ADI strongly relates to rate of repair. From all this work, we highlighted the magnitude of the associations between pretty granular neighborhood socioeconomic level data with increased patient comorbidities and racial disparities. We also highlighted that higher and lower socioeconomic status is associated with fundamentally different types of patients that present for mitral surgery, each with a different set of risk factors, which is important in understanding how socioeconomic status affects mitral surgery patients. Despite the strong associations in patient presentation, we still see an independent association of ADI and outcomes, suggesting that neighborhood level disparity influences outcomes in ways beyond pure demographic and hospital or surgeon level factors. From this, we can say that neighborhood level socioeconomic data might improve future predictive models of patient risk, but may also serve as a target for improving mitral surgery on a national level scale. Again, I'd like to thank the Society for allowing us to present our work. Thanks very much.
Hello, my name is Sloan Guy, and I'm an adult cardiac surgeon from Thomas Jefferson University in Philadelphia. I congratulate the authors of this excellent paper, and I'm very excited to discuss it. The study examines data from isolated mitral valve surgery patients in the STS database from 2012 through 2018 and analyzes clinical results based on the socioeconomic status of the neighborhood that the patient resides in. This is done using an area deprivation index, or ADI, and divides the patient into quintiles, with the highest quintile being the highest socioeconomic status. The data are very revealing and show several important findings. A higher socioeconomic status was associated with higher numbers of males, Caucasian patients, a higher number of elective procedures, and higher volume surgeons performing these procedures. Notably, the higher socioeconomic status patients had higher repair rates of 83% versus 65%, a higher percentage of minimally invasive approaches to their mitral disease, 39% versus 24%, and most importantly, a lower composite complication rate among the higher socioeconomic status patients of 40% versus 48% in the lower socioeconomic patients. There was also a difference in mortality rate with a lower 30-day mortality rate in the higher socioeconomic status patients of 1.3 versus 2.9 in the lower socioeconomic status patients. The conclusion that the neighborhood level socioeconomic data predicts the way the surgery is done, who does it, and the outcomes of the operation are well supported by the data. Of importance, the study clearly shows that lower socioeconomic status patients had bigger incisions, fewer repairs, and worse outcomes in terms of complications and mortality, as well as repair rates. Of course, this is not a new finding in cardiac surgery. Mahaffey et al. In 2020 showed that distressed communities have worse outcomes after coronary bypass surgery in the Journal of Thoracic and Cardiovascular Surgery. In the Annals of Thoracic Surgery, Charles et al. Showed in 2019 that socioeconomically deprived neighborhoods have worse outcomes for cardiac surgery. Interestingly, Billfinger et al. In 2021 in the Journal of Interventional Cardiology showed that while TAVR patients in distressed neighborhoods had differences in their clinical profiles, there were no differences in outcomes compared to non-distressed neighborhoods, suggesting access to care as the primary discriminator. There have been many papers out recently suggesting that certain groups of patients based on sex, race, or socioeconomic status have poorer outcomes. The usual conclusion drawn by others is that such patients are getting worse medical care. But of course, the issue is more complicated. And I think most of us live by the very strong tenet that we treat all patients the same way, regardless of any of these patient characteristics. However, access to care and the ability to travel to high volume mitral repair specialists is clearly revealed in this paper as a discriminator that negatively impacts those living in socioeconomically deprived neighborhoods. Presumably, they have limited resources and options and perhaps information compared to those living in rich neighborhoods. Importantly, Joanna Chikwi et al. Showed in 2017 in the Journal of the American College of Cardiology a direct correlation between high surgeon volume of mitral valve surgery and repair rates, survival, and durability. The study we are discussing today would suggest that much of the differences in outcomes could be explained simply by the lower socioeconomic status patients being denied access to such high volume surgeons for a variety of reasons. It's also concerning that the lower socioeconomic status patients received a minimally invasive or robotic mitral valve repair at a lower rate than the higher socioeconomic status patients, given that we know that such patients can benefit in terms of early return to work, which may benefit the lower socioeconomic status patients even more than wealthy patients. It is noteworthy that Caucasian patients were more frequent in the high socioeconomic status areas than the lower socioeconomic areas, as well as primarily being male. There may be many reasons for this, but the net result is that non-white patients and females experience worse clinical results because of these neighborhood differences. This is, of course, concerning to all of us. So we are left with, how do we do something about this? If access to high volume, high quality repair surgeons for the mitral valve and minimally invasive approaches is the primary discriminator, then our efforts need to focus on improving access to care. Given that the paper shows that lower socioeconomic status neighborhood patients are more likely dependent on government-funded healthcare as opposed to privately funded healthcare, one could conclude that efforts to improve things need to start with access to quality health insurance, as well as, I would argue, information that allows patients in socioeconomically deprived neighborhoods to know about, seek, and receive mitral valve repair surgery from those higher volume surgeons and centers, with the expectations that the result could be similar to those patients from the lower socioeconomic neighborhoods. Thank you so much. I enjoyed this paper, and again, I congratulate the authors on an excellent report.